Awesome.
So I will give the floor to Syairah to start the presentation, and I'll be seeing everyone on later on.
Assalamualaikum and good morning. So we'll be presenting on these table of contents, which are understanding behavior associated with dementia, identifying potential causes and triggers, identifying options for management, and lastly, conclusion. Here's a short video that will give you an overview of Bpsd.
When a person has dementia, some of the behaviours we see can occur because of the physical deterioration of their brain. Behaviour often demonstrates an unmet need. Validation means recognising and understanding that the person's current reality is different to yours.
I have to go. Go away. Hello, Paul. Let me have that remote, please. Yes, I want to have it, please. I want to change the channel. No.
Always remember, when you've met one person with dementia, you've met one person with dementia.
Firstly, we need to understand what Bpsd is. It is a short form for behavioral and psychological symptoms of dementia, and this refers to the range of neuropsychiatric disturbances. Bpsd will develop in more than 90% of individuals diagnosed with dementia. It produces a low quality of life, higher healthcare costs, significant cognitive deterioration, and a substantial caregiver load. Next, we'll be looking into behavior associated with dementia. So Bpsd can be characterized into 5 symptoms clusters, which are psychosis, which includes delusions and hallucinations, apathy, the lack of initiative, aggression or agitation, which can be in the form of verbal or physical, hyperactivity includes pacing, restlessness, and disinhibition, and lastly, affective, which includes dysphoria, irritability, and anxiety. In the purple box here is the characteristics of Bpsd. Next, we'll be looking into the specific symptomatology in psychological aspect. One of it is delusion. The frequency of people with dementia experiencing delusions are cited to be around 10 to 73%, which mostly depends on the study population and the definition of dementia. The most common types of delusions actively amongst all are persecutory delusions and paranoid delusions. What is persecutory delusion? It is when you believe someone is mistreating, conspiring against, or planning to harm you or a loved one. Whereas paranoid delusions, it is the psychosis, the inability to distinguish between what is real and what is imagined. For example, people with dementia often believe someone is trying to steal from them or follow them. So what are the difference between these two? Though paranoia and persecutory delusions are related, they are technically different thought processes. In paranoia, a person feels overly doubtful and fearful of others. These feelings are very intense, making it difficult to trust people. Whereas persecutory delusions occur when paranoia becomes extreme, a person's paranoid feelings becomes fixed beliefs, even when they're presented with opposing evidence. In dementia, delusions can manifest themselves in a variety of ways. The 5 typical delusions seen in dementia, predominantly in Alzheimer's disease, that are documented in Behavioural are people are stealing things. Individuals are unable to recall the precise position of common household goods. They believe that others are breaking into their home or to hide or steal their items. Next is house is not one's home. This means that people living with dementia feel that their house is not their home. From this assumption, the individuals no longer recall or identify their home, and those who reside in institutional settings frequently develop the belief that they need to return home even after many years, and as a result, wandering occurs. Next, a spouse or other caregiver is an imposter. Imposter, we call it in Malay as penyamar. This is classified as misidentification. It is a form of frequent delusion that in some instances can provoke anger or violence towards the perceived imposter. Next is abandonment. It is a belief that that they have been abandoned or institutionalized, or imagining a conspiracy to institutionalize them. But despite the fact that people with dementia experiencing a deterioration in psychological or intellectual skills, some people with dementia retain some understanding of situation. So this awareness of becoming a burden relates to the idea of delusions of abandonment. Lastly, infidelity. In Malay, we call it perselingkuhan. People with dementia were convinced that their partner is unfaithful, sexually or otherwise. This extends to some extent to the carers. So these are the 5 typical delusions seen in people with dementia. Not only delusion, but some people with dementia experience hallucination. Visual hallucinations are the most common prevalent sort of hallucination, affecting over 30% of people with dementia. So these symptoms are more prevalent in intermediate dementia than in mild or severe dementia. However, it is worth noting that the highest percentage of hallucinations, up to 80%, occur in Lewy body dementia, where even auditory, olfactory, and tactile natures are uncommon yet present. Functional impairment related to visual agnosias, which is difficulties in recognizing faces or objects due to problem of contrast sensitivity at low frequency, occurs boundaries of light and dark are blurred. This explains the common occurrence of hallucination and misidentification. So how to anticipate the presence of visual hallucination in a person with dementia? First is to examine their visual perceptive abilities. Second, improve visual contrast by optimizing ambient lighting. And lastly, to educate caregivers on the implications of visual perception impairment for people with dementia on activities and daily living. As for misidentification, it is a form of perception disorder resulted from misperceptions of external stimuli with an association with belief or elaboration that is held with delusional intensity. When an individual are unable to recognize his or her partner, it can be distressing, especially for spouse caregiver. And some individuals who have subsequent aggression may make the symptoms more worrisome. Although there are several types of misidentification, the 4 main types are the phantom border syndrome, the presence of someone in the house, misidentification of one's own self, which is commonly defined as the inability to recognize one's own mirror image. Third, misidentification of others. And fourth, misidentification of events on television. The individual imagined that these events were taking place in real 3D space. To note, the frequency of misidentification will vary depending on the definition of the population studied. The 3 common delusional misidentification is the Capgras syndrome, which is the delusional belief that a friend, family member, and etc. has been replaced by a twin imposter. For example, they accuse a spouse of being an imposter of their actual spouse. Frigolis syndrome is the delusional belief that different people are in fact a single person who is in disguise. Basically, they believe that the familiar person has taken on a different physical appearance but remains the same person psychologically. And lastly, intermetamorphosis is a belief that an individual is transformed both physiologically and physically into another. For example, a man living with dementia mistook his son for his brother. Next, depression. Depressive symptoms affect a sizable minority of people diagnosed with dementia during the course of their dementia, whereas the majority of people with Alzheimer's disease have shown depressed mood to occur as frequently as 40 to 50% of the time. In early dementia, depressed mood and symptoms can usually be elicited according to DSM-IV criteria. So as dementia progresses, the diagnosis of depression becomes more challenging when language and communication impairments worsen and apathy, weight loss, sleep disturbances, and agitation can occur as part of the dementia condition. What to consider when it is called depressive disorder is when or more conditions are noted. 1, acute unexplained behavior changes. 2, displays a persistently depressed mood and a loss of pleasure. 3, the family suspects depression. 4, makes self-depreciating remarks and express a desire to die. 5, have prior family or personal history of depression to the onset of dementia. And 6, rapid decline in cognition. To know, diagnosing depression in dementia is very difficult, particularly in moderate and severe dementia. Next is apathy. So what is apathy? It refers to a lack of motivation to do anything. Apathy and related symptoms are among the most common of the Bpsd, with up to 50% present in the early and intermediate stages of Alzheimer's disease and other types of dementia. Individuals who are apathetic demonstrate a lack of interest in daily activities and personal care, as well as a decrease in various sorts of interaction, such as social interaction, facial expression, vocal inflection, emotional responsiveness, and initiative. The symptoms of apathy may be mistaken for those of major depression, but both apathy and depression can manifest as diminished interest, psychomotor retardation, and lack of energy and insight. So clinician must distinguish between depression and apathy, as each disorder have different managements. Next is on anxiety. Anxiety in dementia may be associated with to the manifestation of other Bpsd, or it may occur on its own. The rates of anxiety may be higher in vascular dementia compared to Alzheimer's disease, and the anxiety decreases in severe dementia. This is because a person with vascular dementia usually has some understanding of their condition, especially in the early part of their diagnosis. So forgetfulness and poor memory is usually not their main symptom. So the person with vascular dementia are aware that they are slowly losing their function, and due to this, they become anxious. Whereas in the late stage, their understanding of the world is very limited, where they are not able to communicate their needs. So this means that they are not aware of what is happening. So due to not being aware, they don't get anxious with their conditions. So for carers, it is really important to be more understanding of person with dementia in the late stage, especially because they have poor understanding and poor communication. So you can't leave them bedbound because they still need to move around and cared for. You also need to talk to them because we do not know what can cause pain or what can scare them. The most common manifestation of anxiety is the Godot syndrome. A person will repeatedly ask questions about upcoming event, and the behavior appeared as a result of decreased cognitive and the inability in channeling the remaining thinking capacity productively. The questioning can become incessant and persistent. This creates major burden for the family and caregiver of people with dementia. Another symptoms of anxiety is the fear of being left alone, which is regarded as phobia. It is an exaggeration of any real danger. This can happen as soon as the spouse or caregiver leaves the room, or it can be expressed as a persistent request not to be left alone. People with Alzheimer's disease may develop phobias of crowds, travel, darkness, or activities such as bathing. Now we're looking into the behavioral aspect. In behavior, we'll be looking at wandering, agitation or aggression, resistance to care, inappropriate sexual behaviors, catastrophic reactions, and sundowning. Wandering resulted many people with dementia being admitted to a long-term care facility. Wandering includes aimless walking, exit seeking, repeatedly attempting to leave the house, and faulty navigational ability, boredom, and anxiety may be the cause of wandering behaviors. As for agitation and aggression, agitation is the inappropriate verbal, vocal, or motor action that is not perceived by an outside observer to be directly related to the person's needs or confusion. So its prevalence increases as the degree of cognitive impairment increases. The development of agitation is associated with comorbid medical factors, psychological, social, and environmental factors, plus the pre-morbid personality. To know better on agitation and aggression, we have provided the subtypes of agitation. Here are the subtypes. For physical and verbal behaviors, it is divided into non-aggressive and aggressive. The examples under physically non-aggressive behaviors include general restlessness, purposeless hyperactivity, and repetitive movements. Physically aggressive behaviors includes hitting, pushing, scratching, and kicking. Verbal non-aggressive behaviors includes constant requests of attention, verbal bossiness, complaining or whining. And verbal aggressive behaviors include screaming, cursing, and temper outbursts. Physical and verbal aggressive behaviors may result from poor social relationship. Verbally aggressive behaviors are associated with depression, pain, and other health problems. Meanwhile, agitation is associated with irritability, disinhibition, and delusion. Both of them are very troublesome for caregivers, and along with depression and psychosis, this leads to the predictors of institutionalization of people with dementia. Next is resistance to care, behaviors that involves in resisting the taking of medications, activities of daily living assistance, or eating. It is associated with the ability of the people with dementia to understand this increase in prevalence with worsening of cognitive impairment. And for inappropriate sexual behaviors, it involves in persistent uninhabited sexual behaviors directed to others or at oneself. They are profoundly disruptive to caregivers, especially family and professionals, and other individuals within the immediate surroundings. It can cause substantial mental and physical harm, as well as pose complex logistical and ethical problems for caregivers. Next, on catastrophic reactions, it is an acute expression of intense anxiety and frustration by adverse experiences, such as frustration with getting dressed, paying bills, or with other such experiences. It is also known as rage reactions, which is typically brief and self-limited and can be managed by avoidance through assigning them manageable tasks for the individuals with dementia. They can also appear as a sudden emotional outburst, verbal aggressiveness, such as shouting or swearing, and even threats or real physical aggression. And lastly, sundowning, occurrence and worsening of Bpsd in the afternoon or evening. Agitation and sleep disturbances accompany sundowning. Basically, sundowning describes as restlessness, agitation, irritability, or confusion that can begin or worsen as daylight begins to fade. Sundowning increases the burden of care for caregivers because it frequently occurs when institutional staffing is at its lowest. Next, we'll be identifying the possible causes and triggers for behaviors associated with dementia. So pathophysiology may explain the cause of Bpsd. Agitation, disinhibition, and psychosis are related with volume reduction and reduced metabolism in the parts of the brain that are responsible of regulating emotions, self-awareness, and perception. It is important to note that there is no single cause of BPSD, and it is critical to go beyond the biological. Biopsychosocial and holistic approaches is one of the explanation that may cause BPSD. So the following biopsychosocial and holistic approaches explain the causes of BPSD. One of it is unmet needs model. This theory explains that problem behaviors of people with dementia result from unmet needs arising from a decreased ability to communicate those needs and to provide for oneself. For example, wandering might be the result of some form of neurophysiological deficit that has caused an impairment in communication abilities. So excessive walking might represent a need to go to the toilet. So as dementia develops, the person becomes less able to meet their own needs and therefore becomes more reliant on carers to help them meet their needs. Another theory that explains the cause of BPSD is progressively lowered stress threshold model, PLSD. As dementia progresses, the person tends to find it difficult to deal with situations where there is not enough or too much stimulation. For example, early in the disease, the person might try to lower the stress around them by isolating themselves in a quiet room. So later in the disease process and the person's cognitive ability to solve problems on their own decreases, the person with dementia might become aggressive and hostile in trying to manage the stress. So the stress they are experiencing. So this model suggests that if the care person can provide interventions to keep stress levels low, the expression of BPSD should be lower. The Bpsd model therefore focuses on supporting the person with dementia through building on their intact abilities and changing the environment and care practice in order to help reduce their exposure to stresses. The ABC approach is also one of the theories that may explain the cause of BPSD. This theory is not a single step, but it is a continuous process of assessing the person with dementia, adjusting interventions, evaluating care, and starting again. So the three main things that needs to be assessed and try to adjust in the interventions are: A is for antecedent, the events or factors that precede the behavioral symptom and contribute to its occurrence. Antecedent are also called triggers because they set off or reinforce the behavior. And B is for specific behavioral symptom that is of concern, looking at one behavioral symptom at a time in the problem solving and care planning process. So we need to look into what's actually happening, what is the behavior, who is it a problem for, when did it start, how often, how severe, and how long. And C is for consequences, the things that happen after the behavior occurs. That includes all the reactions and responses to the person, including those by other residents, family, visitors, volunteers, and staff caregivers. Here's a video that explains the ABC model.
ABC approach to behavior management. There are countless ways to handle challenging behaviors. However, an assessment tool like the ABC approach manages the situation methodically and examines the behavior from a person-centered perspective. The aim is to help us understand the etiology of the behavior, develop a suitable response for ongoing support, and to keep it consistent amongst the care team. A, the antecedent or activating event. The why, what, when, where, and who. Look for direct or indirect triggers of a client's challenging behavior. Let's look at an example. Meet Ted. Ted is an 87-year-old resident of a secure aged care facility who is living with dementia. In his younger years, Ted was extremely active and would wake up early every morning to walk to the corner milk bar to get the newspaper. This morning, Ted wakes up early and attempts to leave through the front entrance with the intention of walking down to the shops to buy the newspaper. B, behavior. Challenging behavior should be documented and defined clearly. You must describe what was observed. For example, did the client yell, cry, punch, or use particular words? Ted becomes agitated and upset, finding himself locked behind the door. He tries to rattle and break the door latch. He is panicked and is loudly demanding to be let out. C. The consequences of the behaviour are the responses from everyone involved. These could include those of the staff, family members, or other residents. The staff member on shift attempts to stop Ted from waking and disturbing other residents. They stressfully shout, escalating the noise. The staff member forcefully grabs hold of Ted's cane in an attempt to stop him from damaging the door. Their response only makes Ted more upset, increasing his distress. Ted's behaviour continues to escalate into yelling and physical aggression. D. Debrief and decide. This step allows the care team to come together and collaborate on the best way to manage the situation. Clients or their representatives should be involved as part of the care team. After the incident, the care team debrief with Ted's family and learn about his history, habits, and preferences of walking to get the newspaper each morning. The team also note that the staff member's response was inappropriate and recommend they take a day off to de-stress. It is also planned for staff to undergo further communication and de-escalation education. The team decide that the morning staff should now have a newspaper ready to offer Ted when he wakes up early and respectfully offer to walk with him around the facility before returning him to his room. The ABC approach to behavioural management works best when the challenging behaviour is clearly documented and understood. The first approach should always be non-pharmacological and should involve tweaking the personal and environmental elements that contributed to the event.
So after identifying the biopsychosocial and holistic approaches that explains the causes of BPSD, we can say that behavior associated with dementia can be viewed as the result of interaction between the damage of the brain structure plus the environment in which the person finds themselves in, plus the interaction with people in that environment. So now I'm going to pass the floor to Hazirah.
Hello, everyone. You're back to me again. So thank you, Syairah, for explaining what were the Bpsds and have explained to us the causes or the approaches to explain the occurrence of Bpsd. So now I'll be talking about more on the triggers on the occurrence of Bpsd. The triggers are quite a bit similar to the causes that Syairah has explained, but the triggers are mostly assessed by the clinicians to understand further on the occurrence of the Bpsd. So it is abbreviated or mnemonic form as CAUSE or CAUSE bracket D. I will tell as I go on why the D in CAUSE are quite different than the rest. So C stand for communication, A for activity, U for being unwell or have an unmet need, S for story, E for environment, and finally dementia for D. Next. So first C is communication. So this is how you communicate with the people with dementia, whether it is person-to-person communication, whether you respect them as an individual equally. In terms of verbal communication, how you communicate verbally. Are you talking too fast? Are you talking too slow? Are you talking too jumbled up? Are you talking too much within one sentence? For example, you're asking 3 things in one sentence. Have you showered? Have you dressed yourself? Or how have you cleaned your room? Something like that. So that could also be the trigger to the occurrence of Bpsd. And finally, in terms of communication, is nonverbal communication. This includes your eye contact. Are you making eye contact with them or are you not? And then your body posture. Are you slouching? Are your body posture doesn't match what are you trying to portray to the individual with dementia? And in terms of your facial expression, are you accidentally showing annoyance? Are you showing that you're sad because you saw them, something like that. So this, in terms of this, are the communication aspects as to that could trigger the occurrence of Bpsd. The next one is in terms of activity. This is in terms of what is the person doing at that time, what is going on around that time, and then is it overstimulating? Are your activities that you're planning to do or are doing are overstimulating, or is it understimulating? And then, or even is the task too difficult? So for example, as we know, the people with dementia do have a decline in cognitive function. So what if one moment you decided to just give them like piles of wages for them to count, like their salary to count? Obviously, that would be triggered for it because they are suffering for they do have a decline in cognitive function. So it might be difficult for them. So that causes the lashing out or the trigger of that, the Bpsds. So now we have an unwell or unmet need. This is exemplified by our doctor. As you know, we do get sick at some point, right? And when we feel unwell, we do feel like too tired or sluggish to want to do something. So this includes such as like having poor vision, hearing, or fatigue, or being hungry or thirsty, having bowel or bladder problem, on medication, or chronic illnesses, and even acute infections. So next. In terms of having an unwell or being unwell or unmet need, we also have being in comfort. Are they comfortable? Whether in terms of inclusion too, are you excluding them from activities, or are you excluding them into another room? And then finally is in terms of attachment. And then we also have pain as the trigger. So like I said earlier, that the individual with dementia do have a decline in cognitive function. And sometimes they do have difficulty in expressing being unwell or being in pain. So if they can't verbally expressing themselves, they communicate through nonverbal expression. Sometimes the nonverbal expression of pain, of frowning, grimacing, or wincing, and etc. So if you didn't catch that or coincidentally overlooked that as a sign, that could also be the trigger to the Bpsd. And then we also have story. This will be in terms of your background as an individual. So this could be your personality, your life story, your experiences, your relationships, your family history, or even dynamics, daily routines, or your interests or dislike and likes. So for example, we have an individual with dementia who likes classical music like Piramli. And then you know that person, for example, dislike heavy metal. And suddenly you give them heavy metal to listen. So that could be the trigger to the Bpsds. And finally is in terms of environment. So this could be light levels of whether the room are dark or is it the room too bright. And then we have signpostings telling you what is where. For example, where is the toilet, where is the kitchen, and something like that. We also have noise level, whether it's too loud or too quiet, unfamiliarity, whether the environment is being too unfamiliar to them, and also in terms of levels of activities and engagement. So next. Finally, we arrive at the dementia, which is the D in cause. The D in cause are quite different than the rest. This is because if each of the cause, CAUSE, aren't ticked to be the trigger of the Bpsds, then the clinician could assess that the cause, the actual triggers to the Bpsd are because of dementia. So this could be in terms of what cognitive function have been affected for the person with dementia. Now we reach the final very big questions that leads to my next point. The question is, can we treat them? So if you have been tuning in to our scheduled webinar, the past two webinar, or have seen through our posts on Instagram, or have no knowledge about dementia, is that currently there are no cure for dementia. There are no cure of dementia. So treatment, treat here, the definition of treat is to give a heal or cure. So the answer is no, we cannot cure them. But instead, we took a maneuver around the question. Instead of asking, can we treat them? We asked ourselves, can we manage them instead? So now we look at the idea of management, which is controlling. So controlling could be in terms of its severity or even the frequency of it. So that leads to my next point. Next. Which is, we'll be identifying the options in management of Bpsds. So before that, we have to know when do the behavior need some interventions. It needs some intervention when it places the individual or the carer at risk, or when it impairs the ability to care for that individual. And finally, it is when it reduces the quality of life of that individuals or others. Next. The next step after you know that the behaviors need some interventions is obviously to develop the interventions. So developing intervention doesn't happen simultaneously, or it doesn't spontaneously occur. It takes a lot of time. It does have a trial and error. So the steps towards developing interventions are three. So we have to go through 3 steps. First is to gather information about the situation, such as where it occurred, what happened that time of the day, who was affected, or how do they behave, or how do others respond to it. And after you have gathered your information, you analyze your gathered information. You identify the likelihood of the causes and the triggers, as I said before, which is the CAUSE bracket D. So that's how you analyze your gathered information. And finally, the important step is to decide how you should respond to it. So this is in terms of what are the options for responses, what is the best options of it all, what is your plan of action, which means from your stage 1 to final stage of the plan, and its backup plan if it failed. And finally, is the reviewing the plan of action over and over again, trying to check whether you need some adjustments or need to change or something like that. So that's how you develop interventions. So next. So in terms of what I said interventions are, we meant is the types of management. So there are currently 2 types of management. We have non-pharmacological management and the pharmacological management. Both of these managements are found quite effective, where the music therapy and behavioral management therapy, also under non-pharmacological management, appear to be helpful in lowering Bpsds. The therapies have been found to lessen the frequencies, the severity of Bpsds, as well as the caregiver burden with effect values to medication. However, it is worth to note that the music therapy and behavioral management technique therapy do require to be done in a caring manner and a caring environment for it to be considered successful. And as of now, there are no FDA approved pharmaceutical classes for treatment of Bpsds, but I believe there's one in UK But on standards, the most common pharmaceutical usage are in terms of antidepressants, antipsychotics, anticonvulsants, and clinitase inhibitors. So next. So these are some of the examples that I have put in terms of what non-pharmacological management is. So non-pharmacological management should be the first in line, that it should be prioritized, a type of management that should be prioritized in managing behavioral problems associated with dementia. So some of this example that we have do happen within institutional environment. It can be done outside institutional, but it requires supervision and it requires prior advice from the specialist in order to do so. So here are some of the examples for the non-pharmacological management, such as firstly, we assert our physical presence and therapeutic touch. So it is beneficial for non-aggressive behaviors. Syairah have mentioned some example of non-aggressive behavior is wandering, pacing, hiding things, and for example, constant request of attention. And then we have constant or repetitive questions, verbalizations, and all that. So these, by asserting our physical presence and therapeutic touch, does beneficial for them. The second one is we create a recreational or social activities. So this allow a sense of structure, meaning, and setting for social interactions. And we also have behavior intervention by completing the ABC chart to establish the appropriate care plan. We have risk assessment, reduction, and intervention. It includes appropriate placement. We also have psychological and psychosocial intervention for people with dementia and also the family and the carers. This could be done in terms of the online support group. We have something like that too. And we also have environmental intervention, such as design and layout of physical environment or day and night routines. So I have also attached later on, and we're gonna watch it, an example of environmental intervention done in one of the care homes, in Australia. So the next one is in terms of compensating for sensory impairments by giving them glasses or hearing aids, attending their diet, and managing their health in overall. And finally is to give them complementary therapies such as massages, reflexology, and aromatherapy. So next. So finally, we have reached the pharmacological management part. So for pharmacological management part, it is a type of strategy that should be considered on each individual basis. So that means it is case by case, should only be considered if the individual Bpsds are causing severe distress to them, or if there is an immediate to danger or harms to other. And then we also have it should be examined depending on the individual and reviewed on frequent basis with the goal of discontinuing if no beneficial effect is observed. So what we meant by that is that ia mesti dilihat, balik-balik, and then kena reviewed if macam indah berhasil ke apa, and then we discontinue it. And then it should only be considered, like I said before, that it is only when the individual is in serious danger of hurting themselves or others, or if durang experiencing agitation, hallucination, or delusion that causing severe discomfort. And finally is in terms of antipsychotics, should not be used routinely to treat agitation and aggression in individuals with dementia. I have attached here some of the example of pharmacological management, such as analgesics, acetylcholinesterase inhibitors, benzodiazepines, antidepressants, mood stabilizers, and anticonvulsants. So next. So now you can now understand some of the behaviors associated with dementia, whether they are psychological or even behavioral. We have identified the potential causes and triggers associated with dementia. And finally, we have also identified a range of options for managing the impact of behavior change for a person with dementia. So next. So here's the video that I have mentioned before.
Okay.
To the situation they find themselves in.
An interesting thing with George is he loves to dance, and if you...
How people living with dementia behave is a result of who they are. Their personalities are often shaped by the events in their life before dementia.
George came to us and he was one of our most aggressive residents. He would lash out, he would push you away, he would grab you, he would just generally be very aggressive.
That's why we must get to know them, each individual and their story.
It's important to remember that the behaviour is always a response to the situation they find themselves in.
An interesting thing with George is he loves to dance, and if you put on music and you offer to dance with George, he will absolutely spend that time dancing with you.
I believe in order to help those we care for with dementia, we need to think outside the box.
We also thought that George was really resistant because he didn't know it was bedtime. So we decided we would wear our pyjamas so George would get a visual clue that it was bedtime. And that worked wonders. All of a sudden, George realised it was bedtime, and George has gone from being one of our most aggressive residents to being one of our calm and happy, settled residents.
So that's all from us. Thank you so much for listening, and we hope our session is informative for everyone.
If you have any questions, you may ask now. You can unmute or ask from the chat box.
I think there's a question dalam chat box.
The X sama B itu represents to show ni saja.
There's a question. I think Syairah or Hazirah, can you check?
I think the question. Oh sorry ya. Mana tiap? Banyakkah pesakit dementia di Brunei ni? So just for that, as of now, there's benda pulang ada specific statistics mengenai pesakit dementia yang ada di Brunei. Tapi kalau ikut statistik WHO yang mengatakan di Brunei should have dalam 2,000 pesakit dementia lah, tapi belum India semua berdiagnose dengan dementia. I think kita ada Dr. Teo with us. consultant geriatric di Ripas Hospital. Dr. Teo?
Oh yeah. So
Yeah.
hi everyone. The question was on statistics, is it?
Yes. Banyakkah induk pesakit dementia di Brunei?
So actually, in Brunei, the problem is most people don't know that it's a dementia or that it is unusual or the signs and symptoms. They think it's normal for old age. So as you say, WHO also people with dementia, and the estimates go up to 2,000. But in terms of diagnosis, because not many people are aware, they tend to come to see us only when it's very late, like when they forget to eat. Whereas actually, if they were just a little bit forgetful, that's when we want to see them and diagnose them, because we have a few investigations that we want to look into to see whether there's anything else medical that we can help to slow down the cognitive or the memory problems. And then for certain types, we can give medications. So in our statistics, so far based on Brohim's information, we only have 200 or so. And WHO wants all the countries to diagnose about 50%. So I'm 500 patients, I think, missing, who are out there in the community who don't know, or people don't know they have dementia and are missing out on potential investigations and treatment. So the summary is it's about 1,500 to 2,000. We have a lot of strokes, diabetes, blood pressure issues. So a lot of them will be vascular from these risk factors. Alzheimer's probably 1,005. And then we only diagnose about 200 or 300 at most. And I've looked through all the specialist clinic. It's not just older people in geriatrics, it's also neurology and psychiatry. Between all of us, almost 300. So yeah, we diagnose about, we have a lot more people who are missing from our registry who we need to catch up and diagnose. But it's actually up to people to come forwards as well to seek a diagnosis to help this. Yeah.
I think Khalid ada soalan, ada plan untuk membuat rumah kebajikan warga emas kali ni ya, maksud kita ni ya, elderly home in Brunei. We are fortunate, alhamdulillah hari ini kita ada wakil dari bahagian Kementerian Kebudayaan Belia dan Sukan. Maybe Kak Erna mau jawab soalan Nani pasal elderly home di Brunei.
Okay, thank you, Bazila. It's true, Khalid, and siapa yang masih ada di sini, it is, yes, it's not recommended sebabnya di negara kita ni masih lagi mengutamakan kekeluargaan itu. Because yang ada dementia ni, they have family diorang juga. So we adalah prioritize family ni untuk menjaga bis diorang lah. Okay, and plans I haven't heard, tapi kita ni di Brunei, kita ni ada pusat kegiatan warga emas and also pusat masyarakat bestari gitu, if I'm not mistaken, that's what they call it. So these are untuk warga emas yang anu pulang lah ni ya, yang aktif lah, but untuk yang bedridden ataupun memang ya di rumah-rumah sahaja di negara kita ni ada bahagian warga emas dan pencen-pencen di Jabatan Warna Masyarakat who work together je sama MOH apa itu ini. So we have namanya program pemedulian warga emas. So that is where anulah kita ni menjagalah kita ni punya warga emas ni. And the thing is with dementia tadi pun Dr. Teo ada mention kita ni inda kita ni pasti bahar macam inda kita ni tahu and kita ni maklum rupanya perlindungan kita ni ada dementia sudah, and it is always associated with old age tapi sebenarnya I think I saw a question je Bazi, sebenarnya apa tu inda semestinya orang tua-tua ni terdapat penyakit demensia ni. maybe Dr. Teo can share sekarang paling muda di Brunei yang dapat dementia, but Ketani yang muda-muda ni lah, kira-kira muda lah tu Indah terkecuali lah daripada menerima mendapat penyakit demensia ni. So that's why we have to be very careful also with our diet, because mungkin macam bagi surprise pulang lah ni sebabnya Indah Ketani dapat memikirkan demensia ni rupanya berkaitan juga dengan Ketani punya permakanan. Jadi risiko untuk orang yang ada non-communicable diseases, contoh yang ada diabetes, yang ada darah tinggi apa itu ini, risiko untuk mendapat demensia ini sebenarnya lebih tinggi lagi daripada orang yang ada penyakit penyakit cemania yang tidak berjangkit. So memang dah ada plan setakat ini untuk mengadakan elderly home ni, sebabnya masih lagi Ketani mengutamakan kekeluargaan Ketani di negara Ketani, and then Ketani pun negara Islam. Okay, so maybe Dr. Teo can share umur yang muda yang ada dementia di Brunei. Dr. Teo, thank you.
Yeah, thanks, Erna. Can I comment about the rest home section first? I think in Brunei, we're all hoping that setting up rest homes or residential care will fix all these issues. In terms of making plans and trying to set up residential care, there's actually quite a lot of things to do. But my personal opinion is that we're not ready for a rest home. We need to little bit, we'll put them in residential care. Or my ama go off on Sunday or something like that. We'll just leave them in residential care. And then who is going to pay for it? Residential care is expensive. So things like food could be considered. I don't know whether, I think our government has covered quite a lot of things for us. I don't know whether the government will want to cover all this. And then the other thing is standards of care in a rest home, because you just put them in a house with amas is not enough actually. We need to train the people there. They need to be patient. You've seen in the video, one person with dementia tried to escape residential care and then they took the cane away and then need to debrief. The staff gets stressed. COVID also is a bit challenging to have a lot of old people in one place. And then based on where I work, sometimes people put their family members in residential care and then they don't visit anymore because they've forgotten, they haven't seen them. And so there's pros and cons. I think for some people, maybe we need to think about community support services. I think we need the community to be stronger first, and then residential care or a them away from family.
Sorry, I think Dr. Teo, you're having some.
That should only be
Dr. Teo is
considered
having
for
some issues with her call.
or thinking too much connection.
Yes.
Can you hear me? Can you hear me now?
Yes, better.
So sorry, I'll just move closer. I can't remember which bit you heard and which bit
you were
don't,
talking about
but
strengthening.
The summary is community.
Yeah.
So I think it needs to be a step-by-step process. We need to think about community support services, because I know in our clinic, we have a lot of caregivers who are a bit overwhelmed with what to do. Staffing also needs to be trained. And then Brunei, we will lose the community and family networking, I think, if we just open up residential care. But that's my personal opinion. I think it will be needed in due course, but I don't know whether we are ready for it yet. In terms of the next question about the age of the youngest person, sorry. So in terms of the youngest person, in Brunei, I look after older people. So I won't see the younger onset dementias. They're usually seen by neurology, But I do know that in Brunei, we have a lot of young people who have had strokes. I mean, we even have a hospital who looks after neurology and stroke, people who have sustained stroke. I've even seen in Brunei, like in their late 30s, they've had stroke because of blood pressure, cholesterol, and things like that. So these people who have had strokes, they're high risk of getting vascular dementia. Usually about 5-10 years, they tend to develop at a later stage memory problems and things like that. And then if it affects function, it meets diagnosis for dementia. So to answer the question, I'm not sure who the youngest one in Brunei is, but I see a lot of young people with stroke, and there will be high risk dementia within 5-10 years. I don't know whether that answers the question.
I think there are two questions on, ada dua soalan mengenai apa yang perlu dibuat kalau pesakit demensia susah mau tidur. I think ada seorang yang bertanya mamanya dia dapat tidur malam, apa yang perlu dibuat. Okay. Jadinya macam tadi presentation Syairah sama Hazirah, dorang membincangkan mengenai melihat dulu apa trigger ataupun cause of kenapa mama kita indah mau tidur. Adakah lampunya terlalu tarang, masa pagi-pagi ia terlalu banyak tidur ke indah, apa yang dimakannya, minumnya sebelum ia tidur. Selalunya kalau untuk pesakit yang pesakit dementia, dorang banyak mau ke jamban malam-malam. I think dorang takut untuk terkamih kali ya. Jadinya selalunya kami punya recommendation sebelum dorang tidur, dalam setengah jam ataupun 2 jam sebelum dorang tidur, jangan dibagi minum lah, supaya dorang kurang rasa mau pergi ke tandas, supaya tidurnya lebih indah terganggu. Mesti juga dilihat kalau whether bising ke indah, adakah ia takut untuk tidur masa malam-malam pasal itu ia mau tidur. Jadi perlu diketahui juga lah kenapa, apa sebab-sebab lain yang boleh mengganggu tidur ahli keluarga kita yang punya demensia tu, terutama sekali sleep reversal, di mana pesakit itu tidur lebih banyak masa pagi dan bangun masa malam, macam si Hazirah sama Syairah ada bercakap pasal sundowning, banyak bergarak-garak lah masa malam. Tapi kalau sudah kita look into semua causes, macam mama kita suruh bangun, kita bawa berjalan masa pagi-pagi, jadinya yang dia tidur masa pagi, kita jaga makan minumnya, yang dia banyak makan minum, bilik itu sudah kita bagi candle lah supaya ia comfortable, semua tu kita sudah buat tapi masih juga ia susah mau tidur. Pesakit demensia ni boleh indah tidur sampai 2-3 hari ni ya. Jadi itu memang boleh membahayakan dorang punya kesihatan bila mana dorang indah cukup rehat, indah cukup tidur. Bila dorang indah cukup tidur, dorang punya kelakuan, behavior dorang dan personality dorang pun lebih terganggu, lebih banyak masalah behavior. Bila mana ini terjadi, bila semua sudah kita cuba buat, masih jo yang dapat tidur, memang ada ubat lah yang mungkin boleh dibagi untuk menolong mama kita lebih tenang. Tapi pasal ubat ini saya pas arah Dr. Tio lah tu, whether ubat ada perubatan yang boleh menolong untuk tidur.
Hello.
Hello, yeah.
Assalamualaikum. Sorry, I just wanted to ask.
Yeah.
Assalamualaikum semula. I'm Haris. I'm just wanting because I go through a couple of the questions on it. Minta maaf Wana, I cut off tadi about the.
It's okay. Teruskan.
Because I'm sure the pharmaceutical or pharmacological management can be assessed in the later future. As you mentioned tadi earlier, Puan Bazila,
yes.
You mentioned that it is far more important to tackle this dementia dari segi rumah tangga lah, from home or household basis.
Yes.
Which I agree. So I'm going to represent. There are a few questions that's similar to my case, which are how do we approach to get diagnosis for patients, in particular for my family would be my mother, who are either in denial or difficult to convince them to get into, to get the diagnosis, especially now during COVID times.
Okay. Thank you, Haris. Ada lagi soalan lain?
Oh, another one is a good one from some other person mentioned today. Since we're tackling dementia from a household point of view, are there facilities that cater to education, educating the families, that to train us to provide better, to become better caregivers for the patients? That's all.
Okay, thank you. So in terms of diagnosis, dari segi macam mana untuk mendiagnose seorang dengan dementia, terutama sekali masa waktu COVID ini, saya will leave it to Dr. Teo lah. Tapi tadi soalan kita, I think lurus tu ada someone was asking kalau ada facilities untuk menolong about caregiver. I think ada orang bercakap pasal support group. So from the hospital, kalau we go from the hospital lah, once you have a diagnosis for your mom, the doctors boleh refer you to specific teams lah. So there are nurses yang specializes in dementia, yang boleh bercakap sama kita mengenai perubatan, cara-cara penjagaan. Nurses ni selalunya lebih kepada masa late stage dementia lah, macam mana memusingkan mama kita, menukarkan pampers bila ia melawan, menukarkan pampers bila ia sudah karau badannya. Atau dari nurses lah, doktor juga boleh merujuk kepada Occupational Therapist. Occupational Therapist ni ia boleh menolong ahli keluarga, help family members to educate you on how to menolong dari segi penjagaan seharian. So the Occupational Therapist will talk to family members, bercakap pasal masalah dari kenapa ia nak mandi, susah mau makan, ada masalah rabah di rumah, behaviornya ni makin teruk during specific time. So an occupational therapist will look into all these issues and try to recommend family members lah on how to tackle all these issues. Tapi as we said, it has to be tailored to that family lah. It's not one solution fits all. Tapi macam saya cakap, ia memerlukan referral daripada doctors lah, and as you said, memerlukan diagnosis daripada doctors juga. But I will leave about the diagnosis to Dr. Teo, if he is.
Yeah, can you hear me? So there are few questions. So in terms of diagnosis,
you're going
people
robotic.
aren't. Yes.
You're going robotic.
Because in Muara the internet not good.
Yeah.
So I've moved my face literally next to the microphone. You can hear, cannot?
Now it's better.
Yeah. My face is really next to the microphone, so I can't do any better. So in terms of the few questions, the first one is diagnosis. Our recommendation, if you have any concerns, the reason for that is because our clinics initially, before we, when we sort of accept from community, is that a lot of our Bruneians have undiagnosed medical problems. So for example, our earlier clinics, we were the 30s who come in and then it wasn't dementia, it's just they needed to be screened for diabetes. As you know, unwellness can cause cognitive issues. And so our recommendation is you go to nearby clinic to seek a diagnosis. They will do blood tests and they will do investigations so that the medical issues which may cause poor memory is assessed first. Then if they are concerned and want further assessment, then they will refer to us in geriatrics for older. If they have behavioral psychological symptoms, it's quite difficult to manage. We sometimes ask the GPs to refer to psychiatry. But all three specialties work together. I mean, we collaborate quite closely with psychiatry to assess these sort of things. During COVID, it's a problem. Not many people want to come to our clinic. So we've had, I think, earlier this month, about 70% cancel their appointments very last minute. So it's very difficult for us. I appreciate there's a long wait list. So I think I saw someone said, well, or something, and our clinics difficult to fit. I guess try to fit people in. In terms of options, because I do agree that COVID, it's a bit worrying to bring older people out sometimes. We actually offer virtual prefer that instead. So we're working through a list to see if that is possible. But the thing is, when you come into memory clinic, we will be doing a physical examination. We will be going through a memory test. So if the person is agitated, angry, they don't want to be there, they don't want to do this test, then it will affect the testing too. So I think we can offer virtual clinic, and then if we do the assessment, that's fine. But I wouldn't drag them in when they're a bit unhappy. You have to choose your times when they can come lah. In terms of facilities for educating families and caregivers, we have our dementia support group, but because of COVID, we have discontinued it. So hopefully that will restart, or we have to think of a virtual approach. In terms of medications, I wanted to ask, other than non-pharmacological approaches, if the person who is not sleeping, do they feel tired? Because some subtypes of dementia, like Parkinson's disease with dementia, their sleep centers are affected. And so if their sleep centers are affected, they don't sleep or need to sleep as much anyway. It's only a problem if they are falling asleep during the day. But other than what Bazila said, try not to let them sleep too much during the day, make sure the environment is suitable. We need to think about subtype as well. So that comes back to diagnosis. Because I have one patient who doesn't sleep alternate days. So one day no sleep at all, the next day she will sleep. And so it's just their sleep center is affected. And in terms of medications, we can try, but sometimes they don't work because, like I say, the sleep center is affected. But sleeping tablets we can consider, melatonin we can consider. So it's really individualized in terms of our approach. Hopefully that makes sense. Thanks.
Sagino. I think Abdul Majid, kita ada tanya, is there any simple questionnaire we can use to try and detect early dementia? So obviously in terms of diagnosis memang memerlukan expertise daripada doktor selatua, tapi dalam kami punya IG ada 10 tanda amaran, 10 warning signs of dementia. So di sana kalau kita melihat ada apa-apa 10 warning signs ni arah ahli keluarga kita, kami punya recommendation is macam Dr. Teo cakap, untuk bawa ahli keluarga kita tu ke klinik berdekatan untuk penyiasatan kesihatan lah, for to check up dorang punya health, to make sure tidak ada masalah kesihatan lain yang boleh menyebabkan 10 tanda amaran ni. So itu kami punya recommendation untuk pasal diagnosis sama detecting early dementia ni lah. In terms of support group for caregiver, sama macam Dr. Teo cakap tadi juga, kami ada pusat amal cerah sejahtera di bawah Kementerian Kesihatan. Tapi disebabkan oleh COVID buat masa sekarang memang discontinued lah. So kalau kita ahli keluarga kita tu diagnose dengan bahagian geriatrik ataupun neurology, dan sekarang ada kena continue support group ni arah Pusat Amal Cerah Sejahtera, dorang boleh offer kita lah servis ni. Tapi macam Dr. Teo cakap, buat masa sekarang memang kena discontinue dululah for now. Nurul Hanisah is asking best solution if dementia patient becomes really aggressive when admitting in hospital. What if the patient does not have any relative? What if the nurses try to calm the patient down but unable to do it? Nurse bunyinya Nurul Hanisah ni. We will get back to you with that. Salwa Jinal is asking, we assume my dad has dementia. Ia pelupa, being confused about time and place, mood changes. Pernah attack kami sampai panggil polis ke rumah, etc. My dad kena bawa ke hospital untuk proper diagnosis. Okay. So for Salwa Jinal, I would highly recommend you to bring your dad to the hospital lah, especially with being aggressive up to a point where is actually harming family members or even at one point probably himself. Jadinya yang ani memang kami recommend untuk bawa ke hospital lah, to get proper treatment. The thing is, kalau kita indah bawa ke hospital buat masa sekarang dan ianya makin teruk, nanti makin payah kita control dan handle behaviornya. Ditakuti sekarang makin agresif bapa kita. Kami pernah ada pesakit, ia bawa mamanya ke hospital, bila mana mamanya cuba untuk membunuh bapanya. Mamanya ya. So we don't want it to be up to that point lah. I don't know if kita mau cakap akan bawa ke hospital untuk bercek sikit damam biasakah saja. Cubalah saja untuk bawa bapa kita ke hospital lah. Because kalau kita mau specialist untuk review, specialist punya review memang memerlukan referral daripada klinik juga. So memang perlu dibawa ke klinik berdekatan dulu, baru tak boleh kena diagnose dengan lebih lanjut lah. Okay. I think Dr. Teo, maybe you can answer Nurul Hanisah punya questions about dementia patients in the ward. Especially those yang no family members by bedside. What can the nurses do to calm the patient down?
Yep. So this quite comprehensively, who is admitted in hospital, they're in an unfamiliar place, and then checks of your blood pressure, we check sugars, it can cause pain, so they aren't happy. I mean, no one's happy when they come into hospital. And so we have to try and know a bit more about the person's background and routines. We have to make sure we explain to people what we're doing, especially if it's something which is quite uncomfortable. And then, unfortunately, in hospital, also people don't tend to get enough sleep.
Macam tercut off, Bazi. No, he's back. Dr. Teo, welcome back. Oh no.
Okay. Yeah, I think Dr. Teo punya connection is not the best.
Yes.
But I think what Dr. Teo is wanting to bagi tahu is for person with dementia yang dalam ward, what we need to understand is why is kenapa dorang behaving aggressively in the ward lah. Macam Dr. Tio cakap, mungkin dorang in the tidur, not sleeping well di ward, for obvious reason, maybe pasal dia terlalu sajuk, bajunya terlalu gatal. Banyak pesakit yang di ward Indah dapat tidur pasalnya bukan tempat biliknya sendiri. Jadinya obviously salah satunya memang bagus kalau ada ahli keluarga by bedside lah untuk calm them down, a familiar face. Tapi kalau tidak ada ahli keluarga, one of the kalau boleh try not to restrain them lah. Selalunya sometimes orang paksakan nak ikat pasal orang menarik hos lah, menumbuk katil. I don't know. I know kalau di ward memang susah sikit untuk ada one-on-one nursing care. Tapi kalau boleh try to understand lah kenapa dorang behaving like that di ward. Maybe dorang in pain. Just check kalau dorang in pain, talk to the attending team whether painkiller can help with dorang punya behavior. Kalau tidur, I don't know kalau mau put dorang closer to the nursing station just so they can see people berjalan-jalan so that they can feel a bit calmer rather than dalam bilik. Selalunya kadang-kadang macam all this doa-doa ataupun music helps with calming them down. Maybe try that as well in the ward. But there are, it is difficult lah, especially in a ward setting where very limited manpower, and then patient ni sometimes mau bergerak sendiri tapi tidak dapat. Kalau ia cuba bergerak sendiri, gugur. So we understand it's difficult lah to care for someone in the ward yang ada dementia.
Do you hear? Is it better?
Yes, we are hearing you better now.
Oh, I've just walked outside and I'm using my phone, so just let me know if it's a problem. So essentially, we have to try to normalize things, make sure the person's aware of what's happening, they're comfortable, eat, drink, sleep. Bowels and bladder, constipation, and wanting to find the toilet is a common reason why people get agitated. And then mobility. I mean, if we stay in bed all the time, we're a bit sleepy anyway, so our thought process is a bit slow. So we try to normalize things. Family is reassuring because at least there's someone who can reassure them. I mean, even our nicest nurse will not be reassuring because they don't know who they are, they're a bit suspicious. And then worst case scenario is we consider medications, antipsychotics, but we only use it as a last resort when a person caring for the patient with dementia, if they're worried about self-harm or harm to other people, like they're hitting out and people can't really be looked after, then we consider the antipsychotic. But usually the antipsychotic, I've heard one of the people who's had the medicine, he said it felt like he was hit on the head with a brick, is how he put it. So it's not going to make their cognition better. It just takes the edge off the aggression. So we try not to use it because it doesn't make their memory better. Yeah, but that's the last ditch resort. I think safety first, and then we try to make sure the environment, I think the priority is the environment and the approach to the person. Yeah, thanks.
Apologies, I think it's 3 minutes to 12 and there are a lot more questions. So I think we just go to one more last questions. We will take note of kita punya other questions and hopefully kami boleh answer your questions dalam kami punya IG. I think Hotline. So Pusat Amal Cerah Sejahtera memang ada hotline yang boleh dihubungi lah. Macam saya cakap, untuk dapat pergi ke Pusat Amal Cerah Sejahtera ni memerlukan rujukan referral daripada kita punya doktor. Jadi kalau kita punya doktor tu merefer ke sana, ada orang dari nurses daripada geriatrik ataupun bahagian otak neurologi akan menghubungi kita lah bila masa ada sudah servis ani ada lagi. Tadi ada orang bertanya pasal hotline mengenai dementia. Buat masa sekarang di Brunei memang ada hotline untuk dementia lah. Tapi kalau kita mau counselling, kita punya stres macam we understand ada masalah care burden lah, especially menjaga warga emas yang mempunyai masalah dementia ni. KKBS ada hotline untuk counselling. Kak Erna, I'm not sure the number doh. Apa nombornya? Apa nombornya tu Kak Erna for the helpline in KKBS untuk counselling?
Bazila, can you hear me?
Yes.
Okay, so did you ask about line
helpline?
Okay, alright, because I think my internet pun jene. Oh, happy Sunday. Okay, di Jabatan Pembangunan Masyarakat, kami ada helpline 141. 141 ni pulang apa tu anything yang bis kita nampak ataupun apakah contoh penderaan ke apakah, and then termasuk juga kalau sekiranya bis kita ingin bercakap dengan kaunselor, tapi 141 ni is pulang yang 24 hours, and during working hours untuk reach to unit counselling dan sukarelawan, line is 2333 141. I will type it in the chat box. Jadi unit counselling sukarelawan, kalau sekiranya bis kita menginginkan khidmat counselling ataupun sekiranya macam indah bis kita mau counselling, bis kita akan mau untuk share and get also guidance ataupun nasihat dan sebagainya, itu insya-Allah boleh, we can accommodate lah di unit counselling dan sukarelawan. So itu pulang saja Bazi. I will share the number dalam chat box and explain lah di sana. So itu pulang saja. Thank you Bazi.
Okay. Maaf kita jadinya I think itu will be the last questions yang kami akan ambil. Pukul 12 sudah. Tapi macam kena mention the chat box. Kalau kita mau copy of the presentation, kita send saja kita punya email. We will share pakai kami punya Google using Google Drive. And I think a lot of the certificate yang askingan ni, I think untuk CNE kali ni untuk